Hello and welcome to the Beyond the Essential Oil Recipe. I'm Elizabeth Ashley, the Secret Healer, and today I am very excited to be joined by my very dear friend, Madeleine Kerkhof, the queen, I have to say, of CO₂ medicine, but the most wonderful speaker on palliative care. And I'm so honoured to have you here, Madeleine. Thank you for taking the time. Say hello, everybody.
Hi Elizabeth, thank you. Hello everybody, great to be here.
Now I'm sure that most people listening in will know who you are and know about your background, but if there isn't anybody, tell us a little bit about where you come from and what your background in aromatherapy is.
Okay, so I'm Madeleine and I used to be a nurse, and in my training and beyond that I got really frustrated about that people only talked about the diagnosis on the staff and not about the patient with the diagnosis. So I got so frustrated that I ended up quitting my job, and I looked beyond the nursing field and beyond medicine and looking into more natural ways and more into holistic care, where we could pay attention to the patient with the disease rather than just the diagnosis. So for me, that was a life-changing experience to go and look in the Netherlands and abroad, because I'm from the Netherlands, and abroad, to widen my horizon and offer patients more care than just for their physical well-being. So that was the reason why I looked in spas, I looked in hospitals for natural care. I looked and I studied with many people more on the job and in practice than in school, actually. And so I really got into aromatherapy from 1991 or so. And then that was it. That did it for me. And also I'm an herbalist.
A really brave and noble leap of faith. That must have been terrifying to make that change.
It was, but it also turned out really well. And I'm also an herbalist and a nutritionist, although I don't work with herbs and nutrition so much anymore. I now mainly am into aromatherapy. That gave me a really good backbone for first treating patients in my own practice. And now I don't treat patients anymore. I only educate around the world, mostly on palliative care and oncology.
And so what kind of nurse were you before? What sort of people did you treat? Were they sort of cancer patients, or was it more general nursing?
Yeah, well, I started out in gynecology. Oh. And yes, unfortunately, by coincidence, or what is a coincidence, of course, there were many patients having cancer. So the doctors would say, "I'm gonna help you. You're gonna help me treat this patient with a uterus extirpation." And but I wanted to take care of that woman who was only 30 years old, who would lose her uterus because she had cancer.
Oh my goodness.
I would never knew that she was going to survive. This is 1980 we're talking. And also she was in crisis because she never could have any children of her own, which she always had wanted. So that was for me a major reason in the end why I needed to look elsewhere, because I couldn't do much for her. I was only 18 and 19 years old. So what did I know? Okay, so I was very young. And actually she died not too long after that. And there were quite some other young cancer patients on my ward. And I think that already taught me that this way of practicing medicine was maybe good for the physical things, to get surgery, to get your chemotherapy, to get all the other things on a physical level, but there was no psychosocial aid for these patients. We didn't even know the word palliative care back then.
Yeah, yeah.
Okay? There were
It's
no
actually we talk as if
Netherlands, so
things
I
have
knew that
definitely
wasn't the
moved on,
way.
haven't they? Yeah, yeah.
But I'm a very empathic, I want to be an holistic nurse, and I want to just look at the whole picture and not just at that. So, but there's much change in the last 30, 40 years.
Yeah, I
Not
think
much
even
as
in
30 years.
hospitals, yeah,
Much has changed. And even now in the hospitals of today, there's much more attention for the whole well-being than only just the physical one. So
yeah, I agree. But I think that also, certainly in the UK, the nurses are so pressed for time.
Oh yeah.
They don't have enough time to spend with patients properly and to be able to give them the support that they do need, do they?
No. So while you're saying that, I'm actually I became very talented in offering nurses means to work with patients, short and sweet, with a large how do I say it in English? Sorry, guys, with a big effect. So yesterday I was in a hospice, and we do an abdominal washing for constipation. Right. So, and then you would think, oh, that will take at least 20 minutes, abdominal massage and stuff like that. But it's not like that at all. It only takes 2 minutes. It's a very technical nurse's intervention. So on the one side, it's not so holistic because it's very technical. But on the other side, it's really enormous well-being. If you can go to the loo for the first time in days,
oh my
just
goodness,
because someone did a 2-minute intervention with nothing than a washcloth and fresh water.
Oh, yeah, that makes a hell of a difference. And so is this so that people can go and have a bowel movement or have a wee?
Yeah. Well, I'm not going into it too much because this is about aromatherapy. But to diffuse an essential oil, if you're trained, diffusing essential oils will take you as much time as opening a window.
Oh, exactly right.
So
yes.
it can be really short and sweet. And because I'm so much, you can take the nurse out of the hospital, but you can never take the nurse out of the nurse.
No.
So I've learned to work with nurses, especially to offer them interventions which don't take so much time, but offer great well-being. And sometimes therapists will look frowning upon me because they have time. And yeah,
but
so
also how rude of them. If anybody of you is frowning at Madeleine because you've got time, consider yourself slapped by me.
I needed to learn to teach therapists because they have so much more time and they have so much more possibilities than a hospice nurse would have. So sometimes I need to broaden my own horizon and to tune into them because they have the possibilities often that nurses don't have. But then I'm an expert in nurses, nurses, and in all fairness, I've achieved very, very much in the Dutch nurses field.
Across the world, I think.
Therapies. And in many hospices and nursing homes and home care, it's now implemented largely because of what I'm teaching. And also because I will not teach them an hour massage because they don't have the time. But they still can do so many other things with scent, with a wound gel, or with an inhaler for nausea, which we make. So that's really great.
Before we go on to that, because I definitely want to explore those areas, I'm interested in why aromatherapy became your thing over and above the nutrition and the herbalism. What was it about that you thought actually that has extra steps?
So now, do you want the honest answer or the diplomatic one?
I'll have the honest one every time. Right. You know me.
Okay. So the diplomatic one would be, I just so love it and I don't want to work with herbs too much. But that's not the real answer. The answer is that if you're in the hospital or in any kind of professional healthcare system, working with herbs is a nightmare.
So I should think it's quite
medication. Patients are on medication. You need to train nurses to become herbalists rather than working with herbs because they need to know the indications, the contraindications, the possible interactions. The time span that people stay in a hospital, it's of course different than a nursing home or a home care, but that's very short. You don't have really time. So herbalists are much better, I think, much better is their role in a private practice or in a doctor's practice. So they can take the time, and they also have time to evaluate their herbs and their nutrition. So for a nurse, and I'm a nurse, that is easy to do. Whereas when you learn, aromatherapy isn't easy either. There's contraindications, there's indications, there is even possible interactions, but there are very safe ways.
Yeah.
Where you don't have to worry so much about.
No, and I think you
You're
get
not
to
going to
learn
ingest them anytime soon,
yeah.
so
You get
it's
to learn
easier.
patterns of where the
Yeah,
problem will be as well.
and
Don't
also
you?
scent.
Yeah.
Scent is amazing.
Very much more luxurious, isn't it? It's
Yeah, but scent does so much with you. You don't have to do a treatment as such to offer well-being. If you diffuse an essential oil which will provoke lovely memories for an elderly patient in a nursing home, you don't even have to touch them if you
No.
don't have the opportunity. So you can achieve so much already in well-being by just diffusing an essential oil or using an aroma patch for their sleep. It's much easier than giving them valerian tea to drink at night. And aromatherapy is so versatile, and that's why
from that point of view, it's
is
passive. Yeah, it's passive as well, isn't it? From that point of view, where I hadn't really thought of that before. So when you're treating patients and training these wonderful nurses who are going out to do work,
which is my main occupation, the training of nurses.
How do you go about assessing what would be the primary need? Do you go in and look at the physical body, or would you address it from an emotional aspect? Or tell me about that. How do you
Okay,
decide?
so when I'm called with a patient myself, I will look at I'm looking at a very clinical way. So I'm going to do an assessment. I'm going to do an assessment. What is the main problem? Usually palliative care patients have more problems than one, but if like nausea.
Right.
See, if they're nauseous and in spite of their medication, then I look first at that issue. Why is this nausea there? Why is it coming from? What can I expect from my treatment? Because if it's nausea from a squashed stomach syndrome because they have a bowel tumor, then the diaphragm will get stimulated all the time, and so they keep on being nauseous and vomiting. But if they are nauseous from chemotherapy, then it's a different cause, where you cannot maybe address the cause, but you will achieve more for nausea with chemotherapy than you would achieve when the cause is lying somewhere deep in the abdomen. So then I look at what kind of essential oils I could use for that, which are a few, 4 or 5 I normally choose from. And then I will ask the patient, what do you like? Are there any fragrances you dislike? I will look at their medical file and see if there's any reason why I couldn't use one of these oils. Okay, so, and then I will make a blend, have them sniff at it, of course, because if you're nauseous, you don't want to smell anything that will make you nauseous.
The
Or
worst nausea I ever
right?
had was when I was pregnant. I couldn't be near a smell. Certainly couldn't be near an essential oil.
So that is all in my assessment. So before I start blending, I have that all in the clear. And then I will blend on the severity of the nausea. I will blend on what kind of essential oils give me the most evidence and experience in treating that nausea. And then, of course, I will also look at the emotional side of it. I don't know if you like lavender.
I like lavender. Lavender's one of my friends. There's plenty of oils that I don't
don't.
like. Don't you? I'm like that about
Don't.
rosemary.
Don't use lavender on my deathbed. I swear I'll come back. Right? So,
Why? Goodness me.
sorry, I like lavender fields in Provence. But I wanted to finish my story here. Because if I would be the patient, I wouldn't necessarily want lavender in this blend. But lavender is actually very calming. So if you have a stressed patient who keeps on vomiting all the time, you may want to add some lavender. So that is how I address the whole picture, even when I treat a physical symptom. But I go very clinical about it. You wrote to me on your email, do you go by top notes, middle notes, and base notes?
Yeah.
I usually don't. I go by clinical assessment, clinical aromatherapy, and I go through all the steps which a nurse goes through when she decides what kind of intervention she's going to give to the patient, whether that is a natural intervention or a normal one, that doesn't matter. And that helps because it gives structure in your treatment.
Yeah, I agree with that. And I have to say, when I write recipes, I tend to go top middle base, but it's a lie, really. I don't normally if I'm doing it myself. So I'm taking it you're going things like peppermint, spearmint, mandarin, chamomile, those kind of, or ginger for nausea, would you?
Ginger CO₂ total extract is my one oil, as in any type of nausea. That will be my main oil. And then I will work probably with some peppermint, spearmint, lemon, because there's
lemon, yeah.
Peppermint and lemon. There is some research on that, and also some lavender. And if it's really, really bad, I will add some spikenard.
Yeah,
I was
going to say in every blend, well, spikenard goes for me. But so we're looking maybe 4 oils, something like that.
Yeah, something like that.
Yeah. And so, what's the sort of main applications that you use the oils in? Then you're obviously talking about diffusion.
Diffusion
for a diffuser, or
diffusion for getting a room clean, either of germs or of nasty atmospheres or tensions, and to make a nice ambience to be in. I do inhalation for nausea. I do inhalation, of course, for respiratory tract issues, and I do also inhalation for sleep and for any emotional thing. I use inhalers all the time. For
so
those
when
patients
are we talking about those little sniffy sticks? That's what you're calling an inhaler.
I love them. I simply love them because it will give self-reliance back to patients. They can control their own symptoms, and especially in nausea and dyspnea and in anxiety. I have them in the plane all the time. So when I go over to Naha in October, I will keep sniffing my inhaler all the time because flying isn't my thing.
Oh, me neither. But you're having me on though. The amount you're traveling this year, you must not hate it as much as I do.
Actually, I do. But I love being there, and I love spreading all these messages I have, especially for oncology and palliative care. So, and then I also use a lot of aroma patches.
Yeah, so no, I have never used an aroma patch. So tell me how we use those. So is it like a lint that you put some oils onto and then you put it onto the skin, or how does that work?
No. It's a little plaster. It's an innovation from America. I got it from I got it from Botanica 2016. I think I met this gentleman, and I sent my own blends to the US, and then they come back in little pouches. And it's like a little plaster with a felty little circle, which will absorb the oil. So you can add like up to the max of 5 oils.
Right.
And then you stick it on the chest of the patient.
Yeah.
Or on next to their chest on their PJs or their pullovers. And through the warmth of the skin, the fragrance will develop it just a bit more. And then through inhalation only, it will get into the nose, and then it will do its magic trick, you hope. So it will not get absorbed by the skin, because I don't want to put pure oil on the skin if I don't really have to. So it's only going through scent. And I use it a lot in patients who don't have any use of their hands to use an inhaler.
Oh, okay. Right? Yes, that's clever.
So maybe they're paralyzed on one side, so they can't turn the inhaler open. Or I will use it when people want to sleep. Or on people with mental disabilities, they don't have any concept of this inhaler to use that. And also, I have been honored to be involved in guiding patients to the last threshold, to the other life, with a patch on their chest. That was really profound, and really, it's such a wonderful thing to have in the last stage. Of course, you have to do it right. You can't do it again. So you need to have your assessment right. You need to have the oils which are suitable and safe. You need to be really careful, especially in the last hours, what kind of fragrance you use and what kind of intensity. But if you do, and if you have all the things right, you can really make the difference between a restless deathbed and a quiet and peaceful one.
And so how are we addressing that? Are we looking at how scared they are, or how are we choosing those oils?
Well, you can look at symptoms which could disturb the deathbed, like the nausea and the dyspnea.
Right.
But usually we care for anxiety and restlessness, and that can really be very helpful
So
to.
what sort of oils would you choose in that situation?
Well, it entirely depends on the patient, of course. But I love mandarin, bergamot, high altitude lavender. So
Oh,
I
they're all
wouldn't use
quite up.
necessarily a normal lavender, but a high
Yeah.
altitude one.
Yeah, the very pure top note, ethereal
Yeah,
note.
yeah, very light, very
Well,
not
they
this.
are almost like
But
angelic notes on the outside of the
I
aura, aren't
still
they?
need to my assessment
Mm.
because if I come in there and this patient is already out of consciousness, so to say, then I need to have a really reliable source from a family member or a really dear friend to tell me, and then I will still be hesitant. But if the patient has been receiving complementary therapies all along the course of their sickness, then you usually know what they like. And then, of course, you can say in advance that there's the possibility to help them along with some fragrance, and then what would they like, and that can be anything really.
Mm, mm, mm. And I think it's very interesting what you were saying about some of them maybe in a coma by this point. We're still seeing the effects. You know, a lot of people will say, "Oh, there needs to be a placebo effect." Well, that can't be classed as a placebo,
Mm-hmm.
can it?
Mm-hmm.
That's very, very interesting. And so,
Yeah, but there's also enough research to say maybe not. We don't do any research on dying patients, right?
no,
So it's not ethical.
ethically, it
But
would,
there's enough research to say that many fragrances have a really calming
of
effect.
course,
Okay,
yeah,
so and
change
also if we address pain also in earlier stages, we know that people that are more calm and can be more serene and have less anxiety, they will have a different pain perception. So they will actually, where we cannot address their physical pain, but they can have a better perception. So they actually will feel less pain. Is that a placebo effect?
No, exactly,
Maybe,
yes,
but maybe, and who
yeah.
cares?
Yeah, and exactly,
Right?
exactly,
So,
and
and
actually,
placebos aren't
it is
bad.
an yeah, it's an actual thing, isn't it? It does make a difference.
Mm,
Yeah,
mm.
yeah, there's definite thing in self belief about it. Yes.
Yeah, yeah, yeah. So, and also for the family members to see that their loved one has been able to pass in peace. Shall I
Mm.
tell you a little example?
I'd love one, except you probably
Right.
make me
So
cry. You
a
know
few years
me.
ago, no, you're not. A few years ago, I was in the biggest hospice in the Netherlands, and there was an old lady. She was in her 80s, and her husband, also in her 80s. They were married for over 50 years. So she got bowel cancer, but she also had dementia, not in a very severe form, but enough to make her restless and worried. And she was yelling and plucking the blankets. And so, because that was on day and night, they both couldn't get any sleep. And her husband, he was afraid to leave the room because he was afraid that she would pass
Mm.
when he wouldn't be there, or that she would get even more restless when she would sense that he wasn't there. So what we did with the nurse, we got 1 drop of lavender high altitude from my friends in the Haute-Provence at Roses, Verdon Roses.
Mm-hmm.
And we had 1 drop of mandarin and 1 drop of frankincense CO₂ select extract. And we did these 3 drops on a little scent device every night. And the last 4 nights where she couldn't have been in any more peace. So that was so wonderful.
Yeah,
The
it's
reason why I chose
therapy for
these,
both of them, isn't it? Then.
yeah, so there was a reason. The reason why I chose these oils was the clinical reason. Like lavender is relaxing, mandarin is highly relaxing, sleep promoting. Frankincense, there's also research that is highly relaxing and very calming on the mind, and in a more emotional, spiritual way, frankincense will help you connect to divine.
Yeah. It's very
And there was
spiritual.
also a very, very personal reason because she loved lavender because they went to Provence on holiday. A
Oh, so I
mandarin
should
oil,
remember it.
yeah, and mandarin would appeal to the child in her, the
Mm.
happy child and the sunny side of life.
Giggly.
And it was so friendly and gentle. And then frankincense was something that she loved very much because they went to church on Sundays, and there the priest, this Catholic church, the priest would do his thing with the frankincense. So it was a very holistic approach to her last days. And what is still choking me up is that it's not only her that died in peace, but her husband who had to let her go after all those years.
From all that
He
anxiety
had more peace about it because she didn't have to be sedated. She didn't have to be, so, and then the memory of her passing would be more peaceful for him because he had to let her go and it was so difficult for him. So it's many years ago now. And the story is also in my book, which I wrote on palliative care. So it's still one of the examples where with 3 simple oils, you can make the difference.
Tremendous kindness.
Yeah. And hey, it's not only reserved for the end of life. You can do aromatherapy in much earlier stages. You can help in oncology with symptoms. You can and I'm doing a pain class for the Heal Center in Atlanta in November, which is not necessarily connected to palliative care, but it is my baby, the palliative care.
Yeah, it's beautiful. I wanted to go back to something that you said earlier about cleaning the environment, the atmosphere of a room. So when you do that, obviously you gave several examples of like the negative energies, the germs going around. Would that be one blend, or would you do it in a couple of different blends?
Yeah, I would think about what kind of room it is, of course, and if people need to be in there at the same time. So I would be very cautious about that. I'm very much against just diffusing essential oils in a living room or in a school or in a nursery just because you can. So if there are people there, I would be using maybe bergamot and lemon and a bit of pine, but then of course you need to be sure that there are no patients suffering from any allergies or anything like that. So in that case, I would wait until the room is empty and then maybe do the diffusing overnight. That can be very efficient. And also if it's like a kitchen or a hallway in the hospital, then if there's not any people, then it's fine to clean the room like that. I feel. I use very simple oils for that, actually.
I think the thing that springs to mind is if you initially when you go into this idea and you think, I'm going to be helping somebody in the last hours, you would imagine you would go sort of very base note sedatives, but actually the ones you're picking are lovely, uplifting, happy, gentle oils, and I think that's beautiful. That wouldn't have occurred to me before.
But it's about bringing a bit of light and a bit of sunshine.
Yes, absolutely.
I use mandarin a lot and I use bergamot a lot because also there is some, it's not big, but there's some minor research on the anxiety relieving aspects of those. But I do use spikenard. But then research has shown that spikenard may interact with haloperidol. And haloperidol is an antipsychotic, which is used in elderly care all the time. Yeah. So, and although the research was done on mice, that it would like oil, we're not sure. So, if I are on haloperidol, I will avoid using a spikenard at the same time. Whereas I know it's a really highly calming oil, but then I would avoid it. So I'm very cautious about possible interactions, and I feel that is my integrity as a nurse and a therapist to really pay attention,
understand them thoroughly. Yeah, I agree. And so with a sort of acute situation, I know, like once I was asked to help somebody write a book about essential oils for kidney patients, and the lady was very interested in how we could help aspects of dialysis and things like that. Do you get involved in if there's problems where tubes have gone in and sores and things like that? Is that something that you get involved in, or is it purely on the sort of more emotional side? Yeah. So what sort of situation?
No, all. And actually, I'm actually more involved in wound care. I get calls about wound care, and it's a tricky thing because a nurse and the doctor I get often calls about wounds that cannot be healed in any other way. So when people are with their back against the wall,
Just a minute.
I get called in.
Just bear with me a second. I'm going to
That is a
stop you.
shame, because that should be done in an earlier stage. It should be done in an earlier stage. But I can understand that when you have this bad wound, that you can't do any other thing. So that is that. I feel that you need to be called in earlier. But
Yeah.
okay, so I had this patient. He had a severe diabetes. It wasn't my patient, actually. He was living far away from me, and his granddaughter, she got in touch with me, and she heard from another experience where I helped to heal a wound that we had so many good results with aromatherapy. And so if I could do something for her grandfather. So we started with carbonated baths, which is a way of bringing good oxygenation to any type of skin.
I have no idea what that is. What's a carbonated bath?
So carbonated bath it's like CO2, but not for extraction of plant material, but you will make CO2 develop in the water for a foot bath. This man had diabetes feet wounds on his feet.
Like retinopathy, yeah.
Yeah, so this carbon dioxide, which when it's in the water, it will attach to the skin with little bubbles. It's like a little bubble bath. And that will help to widen the veins just a little bit in the periphery. Like in the skin.
Yeah.
And that will draw oxygen-rich blood to that skin. So you can imagine that a skin that has more oxygen-rich blood in the skin itself, that is a good it's a good way of helping wounds to heal better.
Yes.
Okay, so we did that. Then we dried his foot and leave it to dry very well, because moist feet is not good in diabetes. And then I applied a wound gel, or rather the granddaughter applied a wound gel, and that she did a few times a day independently of the carbonated bath, and that healed that wound in about 3 or 4 months. It will still take a lot of time, because this was a diabetes patient with a very spiky blood sugar levels. So they would go down and up and down and up. So that's really bad in diabetes. But what we did actually was we prevented his foot to have been amputated, because his amputation was already planned by the vascular surgeon. And he agreed to try, and we succeeded. He now died, the man. He was 80 something. He died of pneumonia, but he had not needed the amputation of his foot, which meant that he could stay in his house and live there happily on his own, and only be cared for by a home nurse and his granddaughter. And that saved him a lot of misery, because a foot amputation would mean that in his 80s he would not be able to live at home. He would have to go to a nursing home, and all the surgery and all the complications. We avoided all that by a simple foot bath and a relatively simple wound gel.
So a CO2 bath, is that something anybody can do, or do you need to have hospital equipment to do that?
No, not at all. You just need a foot soak bath, and we sell it ourselves, but you can buy it also in Germany. There are 2 components. So you add, the one is a powder, you add it to the warm water of the bath, and then you put the patient with his feet or his hand or more in a bathtub, and then you add the other component, and that will by itself make carbon dioxide in the bath. It's very simple. I'm simplicity all over.
I don't believe
that's my middle name. That's my middle. Actually, I have 3 middle names.
I don't believe that. Go on, your
I have 3 middle names. It is safety, palliative care, and simplicity.
There's nothing simple about you, girl. Nothing.
No. Fair enough.
So I'm fascinated. You can't get away without telling me what oils you used. My head would be going myrrh and helichrysum, but what did you use?
I use myrrh. I use helichrysum. I use a base of food grade aloe vera gel, because that's the freshest you can get in my view. I use sea buckthorn CO₂ total seed extract. I use and tamanu, of course. I use tamanu. I use lavender oil. I use helichrysum and myrrh. as you said, and I use a bit of blue chamomile.
Amazing. It amazes me that we're all coming at things from very, very different angles, whether it be chemistry, whether it be etheric, and without fail, we all come up with the same sort of oils for very, very different reasons. Now, I would never have said sea buckthorn CO₂ total extract in a million years, but in every other way, mine would be the same as that. So I'm fascinated to know. Tell me a bit about how different it is using all of these amazing CO₂s you use to using essential oils with these people. What would be the market difference?
Okay, so the short story is that if we talk about distilled oils or CO₂s, which we would use as essential oils, that's of course different than when we would use sea buckthorn oil and sea buckthorn CO₂ total extract. So whereas distilled oils is in need of hot heat, right? Hot steam, relatively low pressure. Carbon dioxide uses relatively low temperatures and high pressure.
Massive pressure,
So in your end product, you will get few more molecules, which will not turn up in an essential oil because they're too light, or too heavy, sorry, to travel up with the hot steam. So let's take ginger CO₂ total, because I'm really about CO₂ total of ginger when it comes to nausea. Because in that total extract, you will find two molecules, which is gingerol and sugarol, which will not turn up in your distilled essential oil. And these are actually researched for their positive effect on nausea. I do tend to use as many oils as I can, which have scientific research backing them up. Like the sea buckthorn CO₂ total extract, I use it for this gentleman's wound because research has shown that it helps to promote the healing of burns, of wounds, and that it will promote peripheral circulation in diabetes patients. So that's a really good reason for me to use them.
Absolutely, can't argue with it.
And it works. And then it's not always the same. Like ginger distilled oil, I don't use that anymore. I only use CO₂ total extract of ginger. But in the case of, let's say, caraway oil, you know caraway oil, right? The carbon content in the CO₂ select extract of caraway is more or less the same than it would be in your essential oil. So if you look at it from a clinical molecular standpoint, it doesn't matter what you use. If you look at the fragrance side of it, then CO₂s are almost always much more fragrant. They will resemble the plant like no essential oil can. And that is just a wonderful thing. Because like in sage, for instance, I don't use sage very much, I must admit.
No, me.
But the sage distilled oil is fine. It's okay. It's sage distilled oil. But if you smell the sage CO₂ select extract, it's like rubbing your hand.
Is it?
It's amazing. It's really wonderful. So that's why I've become an expert on those for the last 10 years or so.
Yeah.
And I've written a book about that, which is very clinically approached. But in every description of the CO₂, which we use as essential oils, I would talk about how I feel you could use it on an emotional level. And I think that especially for the elderly and people with dementia, the fragrances are so much like the original plant that it will provoke
better for the memory, isn't it?
Better for their memories.
I can see that.
Either way, that can be positive and it can be negative as well.
Yeah. So is there ever a time when you would say, actually, no, I would only go for the essential oil, not over the CO₂?
I don't think it's that black and white. In the case of chamomile, that's very interesting. We people that use and sell also CO₂s, we've been puzzled about the CO₂ of blue chamomile because to obtain chemazoline as a molecule in your distilled oil, you need heat. You need water and you need oxygen, right? For that to emerge from a matricine. Now in a CO₂ extraction, there is no water, there is no oxygen, and there is no heat. So we were puzzled because when we were sent the analysis from one of the suppliers, it said camosuline on the analysis, but it turned out that they analyzed the extract with steam distillation, and then you will have camosuline in emerging in that analysis, but actually it's not in the CO2. So I will use, for wound care, for in this gentleman, I will use the chamomile distilled oil and the CO2.
Yeah, yeah. What colour is the CO2 then? What colour is the CO2?
Slurry green.
Oh, how rude for it. It's been robbed, hasn't it?
It is. But the fragrance of this extract is next to none. You are in a chamomile field instantly. Beautiful. Whereas distilled essential oil from blue chamomile is not necessarily a nice scent, is it?
No, right? It's not. So, but actually, as you quite rightly say, you can't compare to its healing properties. So it's been, so you accept
that. You can because research has shown that matricine may have, it's not as an RCT yet, but may have higher anti-inflammatory properties than camosuline.
And you know my chemistry is useless. So what's that in?
So matricine
is that in the CO2?
That is in chamomile and in the CO2, and that will turn into camosuline during distillation.
That's what changes into camosuline, right?
Right.
Yes.
So if you have extract with only matricine and it appears to be more anti-inflammatory, then you may not need distilled oil of chamomile, but there's not enough research yet for me to substantiate that. But so I use the both. So I have the benefits of both those molecules in my wound product, and it's also highly recommended for allergic skin reactions, eczema, because it's a really great antihistamine.
Yeah, I love chamomile. I love chamomile more than I love lavender, I have to say.
Yeah, but there are not many oils that I don't like as much as I don't like lavender.
Peppermint, rosemary and peppermint. Oh, I hate them both. I really hate them both.
And I love those. So there you are.
It's funny, isn't it? Personality thing. So listen, before we move on, anything else that you'd like to tell us about how you've been using palliative care that you think that people would think, oh, that's useful? I'd like to tell them about that.
Yeah, I'm not sure. It depends on. I mean, I can't look at you.
No worries then.
So I don't know who you are.
Everybody I know is going to go, I want to know more about this. So
okay.
We've got 2 books, haven't we? So
we've got 2 books. Okay.
So tell them about your books. So first of all, tell them about your palliative care book. Oh, you're so organised.
I'm so organised.
Have a look.
Have a look.
I love it.
So that is my book, which was published in 2015.
Yeah. And so is it aimed predominantly at nurses?
Not at all. Actually, the history on the book was I wrote it in Dutch first, and it will match the layout of our palliative care guidelines, which are general guidelines for palliative care. So if you read, for a Dutch nurse, if they read the guideline on anxiety, there will also be a notification that there are other options, like with fragrance. And so I use the same sort of layout in my book, but for someone in the UK or in the US or anywhere around the world, they don't use that layout. So that may be a bit puzzling for people to wrap their head around. But it's a very clinical book on the one side, but on the other side, we also address emotional well-being and spiritual care. So it is, although it's called complementary nursing, it is not only for nurses. You can use it as a therapist, and also there are many blends and suggestions which you can use even when people are not in palliative care, but in oncology and they're still in curative stage. But then of course the book is aimed at end of life care.
Yeah.
Okay. So, and it has 10 essential oils, which for me are the red line through the book. Because if you're a nurse and if you're a therapist with little possibilities, then I want these oils to be well-founded, first of all. They need to be manageable. They need to be as safe as they can be without too many issues with the contraindications. they need to be obtainable, but it depends on which country you are, of course, and they need to be affordable. So those are the 10 basic essential oils, with which I've made many blends to start with, and of course there are also other oils, and those are the extra special oils, like some of the CO₂s, the chamomile, but also rose oil, which you wouldn't necessarily have in your basic little package to keep it affordable.
Yep.
So with these 10 you can do already so much, and then there's so many other oils, and I think there's about 30 to 40 oils in there, and some base oils which are relatively obtainable throughout the world.
Yes.
So I'm so practical and pragmatic that I wouldn't discuss oils necessarily which are hard to obtain, because then you make people happy with
a whole new complication. Yeah. Well, okay. And also that people are already dealing with a stressful situation as it is that they need your book. They certainly don't need to be getting into those realms.
Oh yeah, and if you're a therapist, you may already know quite a bit about essential oils and not be at the baseline, but then you get a lot of information on general palliative care. So I speak about the origin of pain. I speak about what kind of pain people in palliative care can have, and where you can address that with essential oils, or maybe you can combine it with guided imagery, so people can be distracted of their pain rather than you going into on the physical side. So there's so much to know about palliative care, and I've tried to compile that in my book together with the blends and the essential oils to make it a complete care book for palliative care with not too many essential oils.
Yeah, I can't recommend it enough to people. And I also can't recommend your CO₂ book highly enough. But I have to say, I never get enough time to sit down and read it. You just, I have to put stickers on mine. I've never thought of doing that. I'm so rubbing that idea. And I hear the bit about cannabis is very good in that book, Madeleine.
I know. I have a really good friend and colleague who actually wrote that piece list.
Shameless.
Thank you very much.
No, thank you. And I have to tell people that I got a letter from the post office saying I got a parcel at the post office, and I was like, oh, what have I got? Oh, it's probably a bill that I haven't paid or something like that. And I went up and there was a lovely surprise free copy. I was so treasure it. I do.
Thank you. Anyway, I treasure your expertise on this, because I'm an aromatherapist and I'm an herbalist, but I didn't have enough background for myself to already speak on cannabis. And also I think on the one side it will be an aromatic which will have its place in aromatherapy, but it's also quite tricky because you need to know quite a bit about it, and also the legal status of cannabis oil and CBD oil is still a bit difficult.
Oh, it's complicated, isn't it?
So, and then I felt I need to go to the only expert in Europe anyway.
Oh wow, thank you.
And to ask, and also I am so grateful to, I'm not sure if they're listening or seeing this, but I'm so grateful to my colleagues who contributed to my book also with their stories and with their experiences. So like Marika Fleury from Malta, and what's his name, Michael Isted with his herbal drink, who we met at Botanica the last 2 editions.
Oh, it's him that had that.
Yeah, it's him. And Ree, of course, Rhiannon Lewis, my dear friend and colleague and educator. So, and quite a few, many more people, and some lovely experiences from Marge Clark and from Lee Wong, who wrote a piece. So, and Priya. So really, really lovely that made this book, which is an A to Z, really, made it come to life. And of course, I shared some of my own experiences with wound gel and the barrier cream which I make, and that's very nice. I think that CO₂ extracts have a really good future in aromatherapy, and I hoped with this book to shed some light on some of the myths and mysteries that are about CO₂s, like that they're always stronger. They're not always stronger. They can be, but they're not always. And also, what are these other molecules? Apart from the essential oils which are in the extract, what are these other molecules about, and what do they do, and what is known about them? And there's still a bit that we don't know, but we're getting there. And of course, there are a few experts.
I appreciate how simple to follow that book is as well, because sometimes you can go into CO2 research and just go, oh my goodness, I haven't got a clue what I'm reading here. In fact, that always happens to me.
I worked my way through all of those.
Yeah, well, I think we're in the
worked
same
my way
place,
through
aren't we?
some books
While you were
about
doing,
the techniques. And also I was helped quite a bit by some of the manufacturers and they opened up to me quite a bit on their procedures, which
that's
is very
generous and helpful.
Yes, I'm very grateful for that. And that you could say that they have a commercial interest in it, but they genuinely wanted me to help everybody understand CO2s better, so we can implement that in aromatherapy. And also, I think it crosses a bridge between aromatherapy and herbalism. And I'm, of course, also an herbalist. Actually, I started out first in herbalism before I went into aromatherapy.
So what's going back to your roots, for fear of a pun?
Yeah, go back to my roots. But also, this book can be useful for herbalists who want to give CO2s internally, even to their patients, once they, of course, with all the safety measures that it will come with. But that is actually a really good bridge between herbs and aromatherapy, I feel.
And tell us about your courses. You like a rock star. You're on tour, aren't you?
All the time, and I don't like flying at all. So there you are. What I sacrifice to be with all you guys.
Yes, right.
So,
you're doing better
yeah.
than
So I'm doing the USA this year again for a whole month, and then I will also do Hong Kong, and of course we now have Kikoza Hong Kong. So the Knowledge Institute for Integrative and Complementary Care also has a premises in Hong Kong, and a chief educator, Kaman Cheung, who also contributed to the book on CO2s. She is our main teacher there, and I go there every year to do specialized classes also on CO2s. I do CO2 extract, a 3-day class with Gabriel Moje next June, and in Hong Kong, and here in the Netherlands. If you want to come over and see the Netherlands, you come in March, because the last 3 days of March we'll do the CO2 course.
that is
in
where
my school.
I am in Seattle with Cynthia. When are you in Seattle with Cynthia?
In Cynthia, it is now in October, 18 to 21.
So it will have passed by the time we get the recording.
Yeah, sorry. So, and I've developed now this program, which is called Fusion Aromatherapy. So that's my integrated approach to using essential oils and CO2s together, combined with all their might and their powers and their fragrances, to help people in whatever they have in the seriously ill patients. So there's a fusion aromatherapy for the very ill and dying. There's fusion aromatherapy for pain, which we'll do in November with Rolls at the Hill Center. And we do fusion aromatherapy in December for elderly care in Hong Kong. And so you can also ask me to come over, but my diary is very, very...
Yours is like mine. It's
ready. Yeah, sorry. And we do this wonderful 9-day program in April, from the 5th to the 14th. We do a 9-day program for palliative care in the Netherlands, in my school. And then you get to know everything about how to support patients in palliative care with their physical symptoms, with their emotional symptoms. We address spiritual care, and we go to hospice and look at what they do there. And we have lovely excursions for you to come with us. And then, of course, I planned it at a time where the tulip garden in the Netherlands is open, and where you can just enjoy springtime
How beautiful.
in the Netherlands. Yeah. So, and next year, all you Aussies from down under, I'll be down under.
How are you?
I'll be speaking at Aromatica in Australia in 2019. And then we'll do a little tour with some courses there as well. I'm so honored that Debbie Atterby invited me, and I'm so glad to see all my Australian friends.
Yeah.
And also
you may be going to Hungary as well to speak for
Gay. Hungary, in Hungary. Also, I'm going to visit Malta and visit
Marieka
and see what she does, and I like that very much. And then in May next year, I'll be at the Integrative Nursing Conference in Galway in Ireland, which is organized by the Minnesota University. So it's a worldwide integrative nursing conference. So all you nurses out there, get your butts to Ireland in May next year. It's 22 to 24. I'm so looking forward to that also, because we need more integrated therapies in the nursing field, and I'm so honored, or not honored, that I may speak. I have actually submitted an abstract for a workshop there, but I will only hear in November whether that's going to be accepted or not. But I'm going to be there.
For you.
It's my main teacher from Kikosa, Hong Kong. So how great is that?
Well, I have to say, I am really looking forward to going to Budapest next year and seeing you and spending time with everybody. So, but probably, knowing you and I, we probably won't even get a chance to speak before then. So, my darling, thank you. That was really very humbling. I'm very honoured.
Thank you too. And thank you, everybody, for listening and seeing me. And I'm very honoured to be a part of the aromatherapy community. And thank you, Liz.
Thank you, darling. Say bye-bye.
Bye-bye.